Bore da bawb hyd Prifysgol Betsi Cadwaladr.
Good morning, everyone.
Diwrnod braf
It's
iawn.
a very nice day,
Yma yn Fenyw
summer's
Cymru,
day here at
Llandudno.
Venue Cymru Llandudno.
Croeso i chi yn
Welcome
ystafell.
to you who are here in the
Os da
room,
chi
and
wedi ymuno
welcome
yn
also to
ar-lein.
those of you who have joined us
Diolch
online.
hefyd os da chi'n
Greetings also if you're watching a recording of this meeting.
Mae'r cyfarfod
The
yma yn bennaf
meeting
i
is
drin a thrafod
chiefly
ein
to
adroddiad
discuss
blynyddol a
our
buddion
annual report
blynyddol
and
sydd
annual
yn cynnwys
accounts,
statudol wrth
which
gwrs.
are a statutory requirement, of
Fel welwch
course.
chi'n
So
agenda,
you will see
mae
from the
gynna ni
agenda that
prif eitem.
those
Mae
are
gynna ni
the
hefyd
main
un
items.
eitem
We do also
ymhlith
have
ar gyfer
a
agenda
urgent
hefyd
item at the
achos
end of the
busnes.
agenda relating to a
Felly,
business case.
i
So
gychwyn,
to
mae'n werth
begin
nodi
with,
does na
it
ddim
needs to
alarm
be noted that
tân
there is
wedi
no
tynnu os oes
fire
angen.
alarm arranged.
Mae
If
yna
we do
hyrwyddiant
hear
angen i
the
ddangos
alarm, there are
y ffordd
signs
allan.
to indicate the way out.
Mae gen i nifer o
We
ymddiheuriadau
have got a number of
gan
apologies
alw
today
o bobl
from
am
various
resymau
individuals for
ffurfiol. Mae gynnon ni hefyd
different reasons.
rhai
We
yn
have
ymwneud
also got
o-lein
some who are
yn
joining us
disgyn
online this morning, and those are
ar
Carol,
gyfer
our
Cymreig
Chief
at
Executive,
Amina hefyd.
and
Felly,
Amina as well.
dwi'n
So
tybio bod yr
I
technoleg yn gweithio yn iawn.
I
Dan ni'n
think
gallu
the
gweld
technology
o
is working
sgrin
okay. We
yna.
can see Carol on the
Diolch yn fawr.
screen anyway. Excellent.
Eitem nesa ydy
The next
estyniadau
item
o buddiant
is
ymwneud
declarations of
ar
interest
agenda. Oes
relating
na
to the
rywun
agenda.
yn
Would
dymuno
anyone like to
datgan unrhyw beth?
express an interest?
Nag oes. Iawn, ymlaen
No?
i
Okay,
eitem
well, we'll
2
move on
ydy
to item 2
adroddiad
then, which is
blynyddol
the
a
annual
gyfrifon.
report and the accounts.
Dwi am un adroddiad,
Uh,
wedyn ni
we'll hear
gyflwyno cyfrifon cyn trosglwyddo
present the report and the
cyllid, a wedyn awn ni at
accounts.
adroddiad blynyddol.
Then we'll go to the annual reports.
Diolch,
Paul, thank you very much. Thank you.
The executives will go and Audit Wales go through the individual items, and these reports have all gone through the various committees. But I just want to bring out a couple of specific issues. Well, first of all, I think as far as the accounts go, the finance department done a tremendous job bringing it all together. They work well with the Audit Wales. But as it's put it in the paper, the first financial duty to break even was not achieved last year. Now, we started the year with a break-even budget, and we ended the year with a deficit of £17.3 million. We're starting this year with a deficit budget, and we're ready into Q1. So the so what from the audit really is, what do we do now? And how do we get ourselves back into balance? So as you look at the various issues from last year, it really is the so what, and what do we need to do? And we do need to get a grip on it very quickly, else we're going to end up in a really bad position by the end of the year if we're not careful. As far as the performance report, overall governance is improving, but we're still having challenges with keeping or driving risk down. A lot of risks are above our appetite, and we're not having some of the responses we need from management, from the internal audits that are being done to get those turned around, and a decent set of governance arrangements at that level where the internal audit actually does the inspection. So overall, I think we're in an improving position, but there's a lot we need to do.
Diolch yn iawn.
Thank you very much. Any questions relating to that report, please? No questions. Well, as has been mentioned, all the reports we're seeing this morning have been before the audit committee, and that was a committee that was open to everyone. I was in attendance as well, and there was quite a lot of questioning and drilling down. Many of the people here this morning attended that meeting as well, so thank you very much for your presence at that meeting. We'll move on then to the next item if there are no questions arising. we accept that report then from the audit committee, which gives us certainty that all the matters have been noted. The next item is the annual accounts, and I will turn to Russell, our finance director.
Yeah, Chair. So yeah, I'll just give you some very high-level metrics from the accounts. So first of all, I'd second Paul's comments. So thanks to the finance team and the wider colleagues who've all contributed to being able to produce the accounts to national timeframes, and then having such a successful audit, and to Audit Wales colleagues who supported us through that process as well. So I think important to record our thanks. The accounts went in on the 1st of May as draft accounts submission. We did reforecast in December at a 17.4 million deficit position from break even, and we attained a 17.3 million deficit at close of the financial year. We have been through the accounts with audit colleagues, audit committee colleagues, and scrutinised some of those inclusions. And we have no change from draft to final position. And we are submitting through final accounts or recommendation through the Health Board to adopt a submission of receipt of the accounts at final stage, which will leave us with that 17.3 million deficit. The audit opinion, following today's endorsement, should we endorse the accounts, we'll go back to Audit Wales, and then tomorrow the Auditor General will sign off the accounts and the opinion will be received back by the Health Board. That will be done on the 26th of June, and the national deadline for signing off of the final accounts is the 30th of June. Just within the accounts, we also had a significant capital programme. I think credit to Stuart and the estates team. I think we've really steered what was a significant programme to a very close to target. So we can't spend more than we've been given, and we can't underspend by more than £500,000 of what we've been given. And we've managed to underspend by £65,000. So we've delivered the key duty, and we've maximised pretty much the use of all of that capital that's come through. So that was no mean feat. So congratulations to all of them and the team. And then, of course, on Better Payment Practice Code. So we are quite a significant partner. We transact a significant amount of resource, and we pay invoices that are duly authorised within 30 days, 96.9% of those being passed for payment. Again, that's a Better Payment Practice Code duty, and we've complied with that to get above 95%. There are two misstatements that were unadjusted. They relate to capital asset system reporting, and it is just an anomaly between gross depreciation and gross value. So the net book value, net book carrying value of all of our assets is absolutely signed off by our audit colleagues. They are true and fair in our account statements, and we're going to work with our system partner to understand if we can, to Audit Wales' satisfaction, move into a different place in terms of how we report that grossing up of the transaction. But the net position is absolutely spot on. And then, as Paul mentioned, we've had a regulatory opinion that is qualified, and that is as a consequence of not delivering the key financial duty of break even. And also we've found second duty in terms of submission of a plan for the following year, which doesn't meet the conditions of Welsh Government for that to be break even. So IMTP effectively becomes an annual plan instead, and the Health Board is asked to go into financial recovery. So that's why it's quite an important aspect in terms of regulatory side through Audit Committee. I'll pause there for my chair. Happy to take any questions.
Thank you very much, Russell. Any questions or any observations, please?
I just want to really make one comment for the record. I mean, first of all, just to say, it is good that we've got a clean bill of health looking forward to from Audit Wales. But I just want to highlight the fact that our spending on primary care in the last year went up by 2%, whereas our spending on care in hospitals went up by 6%. And our actual spend on GMS, on the general medical services, only went up by 1%. So not only are we not achieving the transferring of resources from secondary care into primary care, but it's actually going backwards. And I think part of it is to do with in the last few years, we've always underspent on our primary care budgets. Now, obviously, in a situation in which we're overspending generally, I could see why that can be helpful, but it's wrong. So I just want to put down the marker that, you know, we really need to pay attention to this. If the Welsh Government is going to set us a target of transferring an additional 0.5% of our budget to primary care, I'm sure they'll want to see is not what we put in the budget, but whether we actually spend it.
Yeah, that's a good point, Gareth, and you see that in your role as Vice Chair with overview of primary community care, because as you say, there is an expectation from government that the next financial year, beginning the next financial year, that there is 0.5% increase in spend in those areas, as you said. So it makes very good sense that this year we get ready and prepared and consider how we can do that, what it looks like, and we will have those discussions very soon in order to make some preparation. I know that Carol wants to come in. I'll bring Carol in a minute, but before I do, I'll just check if there's anyone else in the room. Carol, over to you online then.
Diolch yn fawr, Cadeirydd, bore da pawb. I'm sorry I'm not with you in person in the room, but hopefully you can hear me. I just wanted to make a couple of comments. And firstly, Gareth's comment is really, really important because as a board, we have set a strategic intent where we are intending to invest and develop primary and community services and our focus on well-being. So the allocation of resources across the whole healthcare system is really crucial to underpin that strategic intent. Welsh Government often do direct contract, well, they do the contract negotiations and the payments directly to GMS. And this year, they have allocated a 5.7% increase to GMS. I think that's really important. The key task for us will be to ensure that we can have a really clear line of sight to the impact of that in terms of being able to provide sustainable primary and community care. It's more in the primary care lane, of course. And then that second element of moving resource, we've had very active discussions in the executive around this, and I actually attended a summit at the Welsh Government last week around this factor as well. And when we think of budget, we also need to think of the human resource and the expertise resource. So I think, Cadeirydd, this is a point that we would want to come back to, I'm sure, as a board throughout this year, and particularly under the umbrella of community by design. But that is going to be a very important indicator for us to track through. I just wanted to reiterate my thanks to everyone who's worked on the accounts. When they go through the clean bill of health, we can, I hope never, but sometimes take that as a given. But the hard work that goes behind it is really significant. And I do recall my first year here where it was a very different picture. So thanks to everyone who've been able to give us the confidence, including external audit colleagues, that we have a clean bill of health on our accounts. Diolch, Cadeirydd.
Yeah, Carol, for those comments. Anyone else?
Anyone else?
No. Anything else to add? Anyone? No. Okay. Felly,
so is everyone happy with that report? If we are satisfied, then we do adopt the accounts for the 25-26 financial year. Everyone happy to approve? Okay. Thank you very much. On we move then to item 2.3, and this is the annual report. Pam, over to you. Thank you very much. I'm very grateful to the team for their hard work on the annual report.
Thank you very much, Chair, and I just really wanted to say I'm grateful for the whole team that has pulled together the annual report. It's not a one-person job, so from special thanks to Philippa, Diane, and the whole corporate governance team the finance team, communications teams and the wider performance team. This is quite a journey over a couple of months, and really just want to say special thanks to our external auditors, Audit Wales, and our internal auditors, Dave Harris, Nicola Jones, and the whole audit team. I don't think we would be in a position where we are today without enjoying really strong relationships as a team. So just really wanted to make that introduction. I'll just give some high level messages, and I'll pass over to Carol as the accountable officer to add any further context. So really just for the members of the public, general public, to reiterate, the audit committee met earlier this week and have had the opportunity to review the annual report and accounts on a number of occasions. So it has been through that route. We've heard from our chair of audit committee. So from a governance annual report perspective, it provides the board with a comprehensive view in terms of the health board's performance, governance and financial position for the period ending 31st of March. The format of the annual report is prescripted by Welsh Government and has been subject to review by internal and external audit. And following the board meeting today, subject to the approval, the financial accounts will be incorporated into the annual report for submission to the Auditor General for signing, and they will ultimately then form part of NHS Wales accounts as required. So so just in terms of some context for the wider general public. So I think just some key messages we've heard through the chair of audit and through Russell's presentation in terms of the progress that has made during the year, and particularly noting the areas in terms of the breach of the statutory duties. That is transparently covered in the annual report, as we are required to do. So from a governance perspective, the audit committee has through the year received regular reports in terms of any breaches of standing orders and standing financial instructions, and that is covered also in the report. What we have done during the year is where there's areas of risk or concerns, certainly from Carol as the Chief Executive, we have requested additional internal audit reviews, and the board will be aware there's quite a substantial section on issues around procurement. We are, this is because we are taking an active approach in terms of making we've got the highest standards of governance, and certainly with change to the procurement rules, we are seeing a whole range of change in practice. We are not isolated in this. I think it's common practice in terms of common issues across not just the NHS, across public sector. But I think it's important to highlight the change in regulations there. Notwithstanding that, I think it's a honest and fair position in terms of the health board, which demonstrates the progress, but also highlights the significant operational challenges that will remain. And obviously the board has been considering those on a regular basis. It would be remiss of me not just to highlight, as Paul did in his presentation, in terms of those risks that are above the risk appetite, and the board has throughout the year, as you're aware, Cadeirydd, been focusing on the management of risk, but actually we're not yet seeing any change in those risks. So that is certainly a key priority for the executive, as will be for the audit committee on behalf of the board this coming year. So so I think I will just stop there and give Carol, if it's okay, Cadeirydd, to give her a view of the as an accountable officer. Diolch yn fawr.
Diolch yn iawn. Pam? Carol, dros yn ata chi.
Diolch.
Oh,
And Pam, thanks very much indeed. So there's a couple of comments that I would like to give. Some of this I shared at the audit committee, so apologies to those who have heard it before. But in relation to performance, what you might be looking at when you look at what is a very significant report here is where's the focus on quality. So just to confirm that there will be a quality annual report coming to the board in July. I would always have wanted it to all come together, but the regulations don't dictate that. But we will have a deeper look at quality in July. On access and activity performance, I just want to make a couple of comments, really. I want to start with planned care. We know that this is a major issue for the public in Wales and the people of North Wales equally. We know that through our citizen engagement and experience reports that we consider regularly here at the board. We have been able to make really important progress for those people who have been waiting the longest. So approximately a year, 15 months ago, we had about 10,000 people. We got that down to 2,000 at the end of the year. However, that was against a target of seeking to eradicate that. So we didn't quite achieve that. But for those people that were treated, I'm sure that they were pleased with the efforts of so many people across the organisation to increase the capacity to see people. But our big focus now is on eradicating those longest waits at 2 years plus. We have a plan this year to do so. For those waiting for an outpatient appointment, there were about 30,000 people, a bit more than that, waiting over a year. We did a huge amount of work in year to support additional appointments. 45,000 additional appointments were offered, and that reduced the number of people who are having to wait for over a year down to a small couple of thousand. Again, that is a couple of thousand too many, so we are focusing on that. I want to draw attention to the number of people that come to the health board each month with a suspected cancer referral. That's about 4,500 people, and of those, 4,000 people are told that they don't have cancer. That's a huge amount of work, and we are challenged to meet the whole of the timeframes in relation to cancer, the national target being up to 80%, and we are in the early 50%, and there's a plan to make improvements in that area, but a significant amount of number of patients each month are seen in that pathway. I want to stress the work on mental health, because we are an integrated health board, and we continue to meet access standards generally across adult mental health, although there's a lot of other work going on, and it's not just about access. In terms of child and adolescent mental health, there's been a tremendous improvement in year, and huge thanks to colleagues who have been able to enable that to happen. But we continue to have a challenge in the number of people, young people and their families waiting for support regarding neurodiversity. It is a UK issue, but as the board knows, we have redesigned that pathway, and that's already proving at least 30% more effective. The other issue on access is a UEC, and we've discussed this at every meeting. It's our single biggest concern. We have external support arranged with the help of Welsh Government in the organisation. It's multifactorial, and we will, as you say, Cadeirydd, deal with that matter on another agenda item today. But that continues to be a very significant concern in relation to performance and the experience of both patients, but also our staff. On workforce, but pleased to say that many of the metrics are at the higher end in comparison to other health boards, and our retention level has increased and our vacancies have reduced to a low level, although there are some hotspots, and our work on culture continues. You've heard about the finance, so I won't go into that, but just my final comment really is about the governance of the organisation. I'm extremely grateful to internal audit for continuing to be responsive to my requests for additional advisory work. I've always worked in a risk-based approach, so where we identify that there could be a risk or an issue, internal audit are almost always ready to support with a little bit of adjustment at times because they've got already a very busy programme. I am content that the advice that I get from internal audit and the support from external audit means that we get that more independent opinion of our governance, and I've just referred to the structured assessment that also happened during the year. The internal controls, as Paul said at the start of the meeting, are improving, but we do have significant work still to do to be what I would call a very high-performing organisation underpinned by strong governance, but really important steps forward again this year. Diolch, Chair. Sorry, it was a little bit long, but thank you.
Thank you, diolch yn iawn. And just to add to that, because it's contemporary and quite useful, the PPHP committee had sight of a survey of patient experience, which is one of the ways that we gather feedback from the public we serve. We do other things as well. But it was really interesting looking at that survey, what people's experience was. And as you emphasise there, people's experience of using health and wellbeing services in health board is good or very good, save from emergency departments. And what people tell us their experience, according to this survey, and it is a true reflection of life, that people's experience in emergency departments is actually very, very poor. So I think you put the emphasis in the right place in terms of where we need to take the work and the issues that we need to improve on. So thank you for underlining that. And I'm just adding that because it's contemporary, it's just been relayed back to us, and PPHP got that information. So thanks, Laura, for sharing it. Right, unrhyw gwestiwn sylwadau.
Right, any other questions or observations? I'm going to turn to Rhian first. Thank you very much.
Just pick up on something that Carol said, and I'd like to understand a bit better myself. With urgent suspected cancer, the numbers are quite high for waiting, but at the end of the day, when people are actually seen, there's far fewer of them are actually diagnosed with cancer. Now, of course, obviously, it's important to the person that he or she gets a non-cancer diagnosis at the end of the day. But I just wondered, is there extra support maybe being put into primary care to help regarding, I don't know, is it more accurate referrals or dealing with things more within the community? I just wasn't didn't quite understand how this works.
And actually it is a topic that we've been trying to explore further in different meetings. But I'll turn to Clara, if that's in order, so that she can respond to you on that particular issue.
So thank you. So the urgent suspected cancer pathways are designed to have a diagnosis rate of between 5 to 10% cancer. So we sit within that. So they're designed such that if you suspect cancer, you have the ability to be able to diagnose it early, but rule it out early as well. So actually our performance within those is not out with of what one would expect within those pathways. I think we've discussed before equally though that actually what we need to make sure is that we have the ability to see people more rapidly in the routine pathways, because if there's a very long wait to be seen routinely and the balance of risk is around concern, that of course someone is more likely to be directed down an urgent suspected cancer pathway. However, we do now, the triaging referrals that come in as well. So there's work going on with primary care about how best to refer in, but equally when a referral is received, there is review again, for instance, with the lower GI pathways, we've now got specialist nurses who will look at that, decide which pathway it needs to go and go straight to test if necessary. Dermatology, a lot of that now has teledermoscopy, where actually one can look at the lesion of concern and decide whether it needs to go down an urgent suspected cancer route or not. So it is not a failure to have a low diagnosis rate of cancer within those pathways.
Thank you. I think that's really helpful to get that sort of context or background rather than just the headline figure of so many people waiting.
Gareth, Janetta?
Diolch, Cadeirydd. I've just got a couple of points to make, and some of them just because I think some people deserve recognition and some of them are a little bit more critical. But first of all, I want to say it's a very good report. It's an area that we've improved no end in the last couple of years, and I know a huge amount of hard work goes into it. So my comments otherwise are on the substance. And I just wanted, first of all, to echo something that Carol said about our services in mental health and both MHLD, so which is the adults, and the children's CAMS. And I just think I want to put on record that we have got a good record of improvement over the last few years. This is not saying they're not problems, but a real improvement, including feedback from the Health Care Inspectorate on our inpatient wards, where most of the issues they raise are to do with the physical infrastructure, which of course we have little control over. So that is a really real positive, but I also want to recognise that, you know, as I think Carol said, the metrics are limited in what they show, and we know that particularly our community services are under huge pressure, and in that context I want to just put on record and mention for the public the fact that driven by the Welsh Government, there is a new approach to mental health, which is much more based on seeing people in the community quickly. And that is something I think both the staff and myself as the sort of champion for mental health are really supportive of. The second point, I think, was to say on one thing that brings together the urgent and emergency care and the doing more in the community is the issue about delayed transfer of care. So that means people who are sitting in beds, either in our acute hospitals or indeed in community hospitals, who really shouldn't be there. And again, obviously, we all around the table understand that not only is that bad for us, in a sense, financially and resource-wise, but it's also normally bad for the patient. And there are lots of really good examples, including some of the things that we are doing, but not on a big enough scale, of transferring people and services back into the community so people receive services at home. And certainly, so I know there are some examples that are at much bigger scale elsewhere in the UK. And in that context, I'm very disappointed that, you know, we don't really seem to have got to grips with this. So I said, although a lot is happening, that the total of days delayed increased between 2024-5 and 2025-6. And one possible real opportunity, as well as working within our own systems, is that I understand, I'm happy to be corrected, but this was from the horse's mouth at a meeting recently, that the regulations on pooled budgets, which are pooled budgets between the health board and local authorities, have recently changed. So in the past, we could only have a pooled budget for social care on the footprint of the whole of the health board, but we now can make arrangements with individual local authorities. So I hope that's an opportunity to do something about that. My final 2 points are a big shout out, I think, for community pharmacy, because it's a really positive. It's one of the areas that we really are ahead of the pack in Wales, and Wales is ahead of the pack in the UK. And I saw the data that 8,000 consultations per month carried out in the last year compared to 5,000 only a couple of years ago. And those are all people who are being seen in the community, who are not waiting at the 8 o'clock call for the GP. So that is a really positive, and I don't think we often give enough recognise to that. And the point that primary care isn't just about doctors, vital though they are. And the very last point, and this is a bit more sort of carping, so excuse me, but one of the things we did in the last year was we included fair work in our wellbeing objectives. And I just want to say how far we are from actually driving that through, both with our own staff. I was quite shocked to read recently, and I know that you saw it, Cadeirydd, examples in our mental health where our staff were paying for things simply because they couldn't get the procurement done quick enough. And these were basic supplies for patients. And that is really, you know, Fair Work isn't just about pay, it's about the way you treat staff. And even more in a way than our own staff, we also have the issue that we consistently, and we are improving this, it's an area where I know a lot of work has gone on, but we're yet to see the fruits of it in terms of our commissioning and our contracting, particularly with the third sector, where we all too often don't give them sufficient notice of whether contracts are being extended or not. And that we have to recognise is not compatible with treating workers of other organisations, but who are reliant on our money with respect. So I said that's a bit preachy, sorry about that, but I just, it's important to put on the record. But finally, just to say again, you know, it is an excellent report. And I think good reports are ones which also give you the evidence to think critically about what you're not doing, as well as sort of say, yes, we're doing well in some areas. So thank you.
Diolch yn fawr, Gareth. Yes, the annual report is very much a snapshot, detailed snapshot, if there is such a thing, of all the activity, and as you say, should be a tool to help us in the next year and what we need to achieve. So in that respect, I think your comments are appropriate. Diolch yn fawr iawn. Unrhyw arall? Os nad oes, dwi'n droi yn ôl at Pam, dwi'n meddwl, cyn gwneud
I'm going to turn back to Pam. Before I do so, can I also reiterate the thanks to everyone for those reports, the financial and the annual reports. There's been a great deal of work on these documents to ensure that they are correct and that they are a true reflection of our situation. People have been working many long hours on these, so thank you to everyone on this. So I'm turning them to Pam as we bring this item to a close.
Just one minor point I just needed to draw to the board's attention before I turn to the recommendations. So there is a section on data breaches, and you'll see it's on page 62 of the report, the pack. It refers to 5 data breaches in a table, and then the narrative says 3. There has just been a change. Had to correct that data in drafting, so we will be changing the narrative to 5 to match with the table. That's been already discussed with audit. Just wanted to draw your attention to that, and then just turning to the recommendations. I know we will receive the full internal and external audit reports later, but just really wanted to seek the board's approval as per the recommendations. And if I may just briefly run through those, Cadeirydd, just to make sure we've got the correct approval for audit Wales for us to submit. So following consideration today, just seeking the board to approve the annual report in readiness for submission to Audit Wales and Welsh Government. Approve the annual financial statements in readiness for submission to Audit Wales and Welsh Government, and they will be integrated as part of the overall report, and to approve the letter of representation signed by the Chair and Chief Executive on behalf of the board. That is covered in the ISA 260 later on, but seeking the board's approval on those specific recommendations. Diolch yn fawr.
Diolch yn iawn. Pam, pawb yn hapus?
Thank you very much, Pam. Everyone happy then to approve as Pam has recommended? Thank you very much to you all for that. And can we, as we pass by, can we congratulate Pam on her use of the Welsh language as well? She is making a great deal of effort to learn the Welsh language and to use it in her work. So congratulations and thank you, Pam. On now to the next item on the agenda, the internal audit agenda item 3.1. So this report comes from the internal audit team, Pam. Thank you very much, Chair.
Received the head of internal audit report in full. It's here for the board for completeness. It has been included in the annual report. Dave Harry's our head of internal audit, unfortunately isn't able to join the board today. But certainly my and myself and other colleagues around the table would be pleased if there's any questions on that. But it's just to receive in full, has been through audit committee in full on Tuesday, the 8th of hour.
Diolch yn iawn. And as you say, it was in audit committee in detail. Just check with Paul as chair if there's anything to raise or add this juncture.
The only thing is I mentioned earlier that one can look at some of the issues here as own goals because some of the turnaround of management responses could be fixed reasonably easily.
Yes.
Yes, that's what I'm saying.
Thanks for making that point. Unrhyw eisiau codi rhywbeth?
Anyone like to raise anything?
Sorry, I'm being very talkative, aren't I? And usually, just a couple of small points. They're not really questions. I mean, I just wanted to echo, I think, something Paul said in his first intervention earlier, that it's good to see that in some areas where there is only limited assurance that we're definitely making progress. So that's, I think, true in civil contingencies, the standards of business, the implementation of NICE guidance. In all of those reports, although there are things that we really need to work on, it recognises that there has been some improvement. So I think that's important. I've also got a slightly left field comment, and which is just for reflection. So one of the things that's later in this report is some comments on reports that have been done by the Internal Audit Service of other bodies that have relevance to us. And the thing that I noticed is that we often get, and I'm not blaming anybody, there's a very negative picture of DHCW, and that's, I think, partly probably a bit my experience and your problems with their programme management. And yet the audit findings on their programme management are actually really rather positive. So I've just intrigued by that. I mean, probably as Dave isn't here, and anyway, it's not his area. I don't know, but I'd just be interested in that, and maybe I will follow it up separately.
Okay, yeah, just to Justine, and maybe, yeah, we can take that outside of the meeting. And certainly, I think we attended a conference summit.
I think we were Claire, wasn't it?
Oh, it was Claire, wasn't it? And Justine, yeah. Some time ago, where there was a feeling of reset. Really, I think that would be fair to say in terms of the digital ambitions, and there's no question about the ambition of the current government that has the previous government in this space. So yeah, we will follow that. So that's okay, Justine. Yes, please do.
Following receipt of our Audit Wales report as well, there's common themes across Wales.
Yes.
So they are going to be doing an audit of DHCW and Welsh Government as well. This is some common themes.
Oh, good. Okay. Yeah, great. Yeah.
Diolch yn iawn. Unrhyw un arall? No.
Anyone else? No? Everyone happy to accept that report. Thank you. You all for the work too. We'll move on then to 4.1, the next item, and this again this is Audit Wales and their view of the financial reports. Pam.
So again, this has been received in full at audit committee. The auditors present where Caderi, you were present along with Carol. It's to give full-sightedness to the reports. There's nothing further I feel I needed to add. There are some areas which we will work through in terms of improvements in the next year, and that will come through audit committee. And one of the areas I think, Paul, you mentioned at the audit committee was just as part of some of that work, about some assurance in terms of some of that work, particularly around some of the arrangements in relation to senior appointments. So just what I call some housekeeping that we need to do. And important to note, we've actually made quite big strides in the last couple of years around some of this. So other than that, unless there was anything further, inviting the board to receive it, probably covered it for in other committees and part of the annual report.
No, diolch yn iawn Pam. Unrhyw sylwadau, unrhyw gwestiwn?
Thank you very much, Pam. Any observations, any questions? If there aren't, everyone happy? Russell, sorry.
Chair, only really quickly just to point out on page 7, Chair, so just the level of materiality and the level of work that's undertaken through Audit Wales. So materiality thresholds are set at 1% of turnover, which is 26.47 million. So that means we spend annually 2.6 billion. So we're a significant organisation. But the reporting threshold for members in this report is 5% of that materiality. So 1.3 million as a set threshold. So above that, if there had been any errors or concerns, they would have been reported through this report. So it is quite a high degree of analysis, and there's significant work that has to be undertaken, of course, to get to that assurance level. So it's just to point out to members, Chair.
Diolch yn iawn. Unrhyw sylwadau?
Thank you very much. Any other comments, any questions? No, everyone happy then to accept that report. Thank you to our friends from Audit Wales for their work and their support, and thank you to the team in the finance department as well. Right, on we go to item 5, which is our final item for the morning, and this is the business plan. I'm going to turn to Claire as the medical director for this report.
So, first of all, I'd like to thank all the staff who work in our EDs, providing emergency care day in, day out for our population. And of course, as a board, we fully recognise that patients are waiting for prolonged periods of time and committed to improve that. And we've already discussed associated with experience with that this morning. We will say, though, that patients on the whole are very complimentary about the care when they receive it, and the way they're treated by staff, recognising that they're working in very difficult circumstances. We know that having stable and consistent staffing is key to providing quality care, and this business case to that effect is primarily a patient safety last. So over the past few years, there's been a need to increase the number of staff working in our emergency departments, and this is despite the fact that attendance itself has increased only a minor amount. And this is broadly, twofold. First of all, there are now many patients waiting in our EDs for prolonged periods of time, awaiting a bed in the hospital. And if you look at the supplementary evidence pack, you will see in what I call tartan blankets and heat maps on there, that although attendance is broadly similar occupancy, that is the number of people in the department at any one stage, has gone up substantially during the last 2 or 3 years. And these patients obviously need nursing care. And therefore, this case is to increase both the registered nurses and the healthcare support workers to be able to care for those patients who are unfortunately waiting within our departments for long periods of time. Secondly, there's an ask around the non-consultant medical rotas. And these rotas are needed so that you've got the right number of staff matching patient arrival times, but also to be able to maintain rotas that are sustainable and meet working time directives for the staff who are working within them. And there's national guidance associated with those, and all of our departments actually have had external reviews associated with this, with recommendations associated with those rotas. So over this period of time, we've increased the staffing as is required, both to care for the patients and to be able to rota effective medical numbers of staff, but this has been used using temporary staffing. Now, all staff work hard in our departments, but using our own substantive staff is the best way to provide consistent, productive and cost-effective care. And it also is safer in that it then ends up with fewer rota gaps when we're relying on temporary uptake. Now, the financial ask within this case is substantial, and I'll walk you through it now before I give you slightly more details on the case itself. So the total increase in budget is from 24.8 to 32.9 million, and thus an increase of 8.1 million. However, 1.4 of that is already in the IOC budgets associated with part of the 42 million conditionally with current funding.
And IHC, just to point out to people,
is within the ED's budgets, yes. So within the integrated communities budget, so within the sites budgets. A further 2.8 million has been prioritised previously in 25-26 for the increase in the nursing ask associated with this case. That leaves another 3.8 million. And I think it's important to note that all but 1.4 million of that was spent last year to cover temporary staffing needs, along with the two elements that I've just described. And this will need to continue to provide safe staffing. We can obviously discuss that in more depth if it's helpful to people. We've also used the opportunity within this case to expand for board some of the further issues about ED with relevance to this business case. We recognise, of course, that this funding will not solve all the issues identified within our emergency care pathways, but it is part of a programme of work within our EDs and outside of them to make sure in the hospital and in the wider system. So in particular, within this case, we've outlined the standards of care that should be provided within our emergency departments, both from professional guidance and the Royal College of Emergency Medicine and from NICE. And these are generally reflected into a proportion of the national key performance indicators that we're measured against. We've also outlined within the document the staffing guidance and particular notes there again to the Royal College of Emergency Medicine guidance. And of note, at least two, if not all three of our emergency departments fall into what are categorised as smaller rural or remote emergency departments, where it is noted by the Royal College of Emergency Medicine the staffing challenges associated with this, because you have to be able to maintain rotas for staff that are acceptable, and thus the cost per head of caring for patients in such units lacks economy of scale, because if you had a large unit, but of course has advantages associated with access for local population. We've also outlined where we are against these standards, particularly with review of some of the from Health Care Inspectorate of Wales over the last few years. And of course, we note the recent inspection at the Glenclwyd site with escalation into a service requiring significant improvement, and we will look at that further in the Quality Experience Committee next week. We also look at the standards associated with getting it right first time, GERFT, and all of these inspections and external reviews note the issues with the hospital and system flow, as well as issues within the departments themselves. None of this, of course, is new to the board, but we thought it'd be helpful to collate it in one place. Board is, of course, also aware of programmes of work in place that we discuss regularly, including those supported by external help, which we updated on last month. In particular, the discussion around discharge to assess models, helping those who are staying in our hospitals for long periods of time and developing a shared purpose with local authorities, and the 6A's audits looking at those at tender. We also know we've got 90-day plans in place with a wider urgent emergency care plan, taking in the national asks, but adapting these to the localised high impact actions, and these are closely monitored by the executive team and the board. We're all committed over time that these actions will lead to reduction in overcrowding in our EDs and produce better patient flow, and thus some of the nursing ask may therefore be transitional. However, we are not in the situation where we continue to provide care using temporary staff whilst this reduction in occupancy occurs. Within the case, there's much more specific detail and information about how the staffing ask will improve patient safety and performance indicators, which I'm obviously happy to answer any further questions about it. I just want to read us through the recommendations associated with this, and then if it's all right, Chair, hand to Carol just to any further questions. So we got to note the sustained and material patient safety risk within the emergency department as previously reported, and through the escalation board and healthcare inspector at Wales to approve recurrent investment of up to £3.9 million to stabilise the emergency department workforce capacity to respond to this risk. But there is some further work that we would want to do just around the final deployment of this, specifically relating to staffing patterns of deployment to match demand and capacity. I have that now in my inbox, but we're just working that through over the next few days. We acknowledge this investment is not within the current financial plans and will require organisational reprioritisation. We agree a phased implementation approach because, of course, we need to recruit staff to this. So, of course, this will not be a full in-year effect. We require the executive to develop and deliver a clear benefits realisation plan, demonstrating how this investment will improve performance, and agree oversight and assurance through appropriate committees. Thank you. I don't know whether Carol has anything to add.
Well, we bring Carol in later because we have a slight technical hitch
so we do.
at the moment. Let's blame it on where that is. Oh, she's back in the room. But we'll let Carol make sure she's connected fully. And just before Carol comes in, Claire, many thanks for that, and thanks everybody for the work on this. It does come back on the back of the HIW Health Inspector at Wales report, but it hasn't really been instigated by that, has it? It's been long running this, and it has come to fruition now that we are very glad of, but perhaps there was an opportunity for us to do it sooner, but we have to deal with what we've got in front of us today. A very detailed business case. I'm going to ask you a really difficult question now, because it is not a button to press and everything falls into place. It's not quite as simple as that. But for our residents and people who are going to be using the service, and equally our staff, what sort of improvement or change do you think it would be correct for us to say this is the difference it's going to make? And it's not maybe one difference, but I just want people to get a sense of this is really important because it's an investment that's going to improve experience for patients, staff, and outcomes therefore. So just I know it's difficult to put in a few words, so I'm putting you on the spot, but give it a go.
No, that's fine. So I think that fundamentally, in order that the emergency departments are not easy for both patients or staff at the moment, we know that. And to have substantive staff who are our own, who know how to work to the standards that we have and to work productively to that, and who then we are able to fill the numbers of staff that we require very predictably into those posts is not the magic bullet, but will make a substantive difference. It's really simple things like triage by the nursing staff is a skilled job. We need skilled nurses to be able to do that, and we need to, on occasions where we're really busy, to be able to double up so that we have more than one member of staff to be able to do that. In order to be able to do that, we need staff who can do that. From a nursing perspective, we have people, as we know, in undesignated areas to be able to provide them reliably with staff, both registered nurses, but also with our healthcare support workers who are able to support their care within the environment that we know is tricky, and to do that within all of our protocols and be very familiar with those. It's really important. And not only within protocols, but of course within an environment, it's about relationships and being able to work as a team, and therefore to have substantive staff who are able to work as a stable team in this environment is really important to make sure that we are providing the best care that we can.
Many thanks for that. I think that does underline the need to create that stability in in the way you described. So I think that's useful for people to hear. I'll bring Carol in first because now we have connection
To
working.
Cardiff.
And then I'll bring Claire in next. Diolch yn fawr, Carol.
Diolch yn fawr, Cadeirydd, and diolch yn fawr, Clara, for presenting the case. There's been a lot of work gone into this, and for those who have the time, the opportunity to look at the supporting pack that has been developed as well, there's a lot of very important information in there. We know that the challenges around urgent and emergency care are throughout the system, and Gareth referenced that very eloquently earlier. And so whilst this is a case about the emergency department, we must retain sight on the whole pathway. And as we sit here today, we still have over 300 people in our hospital beds who whose pathway of care should have helped them to move on to somewhere else, sometimes home, sometimes another care environment. The reason I draw that in is because that directly affects the levels of overcrowding in the ED department. And the more overcrowding you get in the ED department, the worse the patients and staff experience, but also the greatest challenge to patient safety. And Claire is absolutely right that this is a patient safety case. So some might challenge, well, why are you putting more money into the ED when clearly the problem is elsewhere? Well, we have got to take steps to improve the safety in the department, whilst also investing and changing processes elsewhere. So this isn't a single approach here. We're not just putting more money into an area that is particularly challenged. We are looking at the whole UEC, and we'll bring back reports on that. One of the things that I've been very keen to do, and we've had great support from data analysts in this regard, is to use the evidence to help us to understand how our staffing patterns should operate. So our departments are the busiest, with most people arriving from early afternoon into the evening. But if we don't have the staffing complement to match that, patients are then more or less here overnight as well. So you'll see the 12-hour waits in the ED department are very high at the moment. We want to get those down to 1 in 10 rather than what is 1 in 4 at the moment. So it's really important milestone now. We have got some investment set aside, but we will be needing to resolve that final financial part, and we have further discussions ongoing around that. But we have agreed as an executive team that this is a key priority. So all of the executive team are supporting this to go forward, Cadeirydd, and there'll be an implementation plan, including that additional work on roster and how we deploy the staff. So I'm confident, given this is our biggest safety issue, that this is a really important step to improve safety and patient and staff experience. Diolch.
Diolch yn fawr, Carol. Reit, unrhyw sylwadau, unrhyw gwestiynau?
Thank you, Carol. Any observations or questions from members, particularly independent members, as this has been before the operative team? I'll begin with Dyfed here, and then Claire. Thank you. This is very relevant. A few weeks ago, I was able to spend time at the emergency department at Ysbyty Milwr in Wrexham with Clara and with joint members of the group. And we had the opportunity there to see the department functioning under the pressure it works under. We had interesting conversations, but very open conversations as well with some of the staff we met about those challenges facing them. So this is, of course, to be welcomed. But as Carol has suggested, this is part of something wider. And I go back to Gareth's point earlier about the collaboration which does work very well in certain areas with local authorities, but there's a need for us to be able to ramp that up, so to speak, and make it work better in some areas. That is also going to help that flow through the department. But yes, I welcome and understand, and Clara has explained it very well to us in terms of how important this is within the entire system. So very glad to see this brought before us and to be able to support and approve. Thank you very much, Claire. Thank you, Chair.
Anything Doug said, but because I arrived late, I haven't got my translator. And Carol actually addressed some of the key points I was going to raise. So I think the first thing I wanted to say is I'm very supportive of this in principle. It needs to happen. It should have happened a long time ago. I think we have to acknowledge it's taken us far too long to bring this to the board today. That's no reflection on Clara. She's only been with us a few months. But it feels to me a bit like a nurse staffing that kind of paper in a sense, which is these are the kind of safe levels of staffing you should have, and therefore we need to have them for all the reasons that Claire has identified. I think, but we do need to acknowledge that the numbers of people attending, according to the business case, have only risen slightly. So this has been an ongoing challenge for some time.
Yes.
And I think it's really important that we acknowledge today that this is a very, very small part of addressing the whole challenge around urgent and emergency care. So I think I've got kind of a couple of questions to the exec. One is we will need to make further in-year savings over and above what we already are needing to make to fund this. So be useful to understand, like Carol said, this is owned by the whole exec, brilliant. Where we're up to in terms of the work to identify where we can make these complementary savings and when we're board be able to see those. And I think it's just, I say, really important to recognise the biggest barrier to improving ED is getting people out of hospital when they're ready. And that's not a new problem. That's a problem that's been an issue for this health board. The numbers have not reduced at all in all of the years that I've been involved in Betsy. So even when I was in a different role to the one I am now, so this has not been an issue for 5 years. So I think it's important for the public and those who listen to and understand what's going on our board to get a bit of a feel for when we might be bringing forward, if you like, the other pieces of the jigsaw, which are also part of addressing this big long-term challenge. But I am very supportive of what's been presented to us today, Diolch.
Diolch, Claire, and I think you highlighted the matter that this is a strategic decision that the board makes, and its approach then is to say we will ensure that the appropriate funding is there to make sure we can deliver on it. Now, equally, we need a strategic approach to ensure the savings corresponding and otherwise are there so that we can make this happen. So I think that puts it in that space. So thank you for that. People just want to come in, so I'll turn first to Paul with it. Gareth.
I think Rhiannon showed before me, Chair.
I've got Paul, Gareth, Rhiannon, and Adrenda now.
Can I start to say I'm fully supportive of this? Early in the paper, it does say this is the minimum that's required. It always worries me when I see minimum. That normally means you've got to come back and ask for more. Why have we not gone for the optimum? And if we go for the optimum, it gives that slight amount of flexibility. Which takes me onto my second point, but I think Claire's covered that fully. Making decisions like this are easy. But on the other side, we've got to make the savings decisions. And we do need to force ourselves to discipline of actually finding the savings for this in a short period of time, so we can balance that out. And the third one, I think Claire answered it within the piece on roster, but I can't understand why this was not put in the budget. The budget is only 3 months old. And so why was this not part of the annual planning process? So it could go into the budget, that we could actually account for it within, rather than having these requests in year. Why have we not? Why have we left it for 3 months in year? And is that a roster problem, or is that You know, the discipline should be, all of this should be there at the beginning of the financial year.
Thanks, Paul. Sorry. So Rhian, Nessa.
I think most things I was going to say have already been covered, really. I think the basic principle of if we shouldn't be doing interim, bank, none of those things, if there is a substantive need.
Yeah.
So I would support that element, definitely, to have substantive staff in post and adequately rostered. I like the bit about up to 3.9 million rather than 3.9 million, because that means you might need 3.9 million, bearing in mind that it has to be set within the overall context that Claire and Carol have talked about. You know, it's just one part of the jigsaw. So with those things in mind, and other people have said everything I was going to say anyway, I'd be supportive to that point. Yeah.
Great. The point about bank and agency is well made, and we do appreciate the work of people who are on bank and agency, and we know that some staff actually are getting into a place because of their context. They quite like doing bank, so that's a good thing. But I think the point you have made is to do with, you know, let's be absolutely clear, the needs of a department service organisation, and that does mean ensuring posts are filled and not relying on bank and so on. I think that is a central point, not just in this area as well. Gareth,
that was really the point I wanted to make. This is an excellent report and I really strongly support it. But there are lots of other places where this is true, that I recognise that there is a net increase in cost. But in many cases, for a relatively small amount of extra money, or indeed for the same money, we can get much better quality and sustainability of services if we replace temporary sticking plaster solutions with sustainable ones. And sometimes that's about the theology almost of saying, well, we don't have a guarantee that this is in our core budget from the Welsh Government, therefore we can't employ anybody permanent. In our risks, our risk strategy, we say that we've got an open approach to financial risks. We don't practice that in reality and say, well, actually, sometimes we need to take the risk to balances with other things. And we did this about a year, 18 months ago with oncology, where we had a similar thing. And we were trying to use sticking plaster solutions instead of employing full-time consultants. And we bit the bullet with that. And I think it's, you know, we've yet to see the full benefit of it, but it's certainly improved matters. And just to prove my point that actually it's not always, oh, we're going to spend more money. No. One of the things I persistently come back to, and apologies for colleagues on the Performance and Finance Committee, but is that we are consistently, significantly below our establishment. In other words, we have more jobs accounted for in the budget than we have people employed. And when I say significantly, we're talking 1,000, 1,500, and yet we consistently overspend on staffing. That can only be because we're adopting more expensive sticking plaster solutions instead of actually filling our substantive posts, or there's something very wrong with our budgeting, but which there are probably some things wrong with it. But so, you know, please, let's treat this as a precedent. Obviously, we need to have good business cases where there's significant change. Yeah. But in many cases, I said, we already have the staff in place. They're just not permanent staff and they need to be.
Diolch, Gareth. Rhywun arall? Billy. Nessa.
Anyone else? Billy next. Then Helen.
Whilst I really welcome this, it's an important move to improve quality of care we're giving to our citizens. I do worry that we're normalising corridor care. It's a bit of a chicken and egg situation, I suppose. So I do welcome Carol's assurances that we will be moving in other areas a little, but I would urge the health board to go harder and faster.
Yeah. Many thanks for that, Billy. Very important point. Helen, Nessa?
Diolch, Cadeirydd. I just wanted clarity because I know that staff and there will be other people watching are really interested in this particular item. I wanted just some clarity on the extra investment. Lots of numbers in the paper, and I'm hearing it's 3.9 million. So it was just a clarity on that, so that it could be clear.
Okay. Yeah, we're asked to approve recurrent investment of up to 3.9 million, and the term up to is very fashionable these days when people are talking about budgets, it seems. So I will just check before bringing Clara, and I know Russell is writing frantically, so he'll want to say something. And I'll bring Carolyn at the end. Anybody else in terms of independent members in particular? Okay, we'll go Clara, Russell, and then Carol in that order.
Thank you. So, I mean, I think we all agree that this is, you know, part of a wider programme of work that must be done to accelerate alongside this. I think that, as Billy said, none of us should be normalising care in undesignated areas, be that corridors or elsewhere, and is not something we would want for our population. But equally, and I think we've all accepted this, whilst we are doing that, we must make sure that people are cared for appropriately in those spaces. I'll answer some of these and then hand them across. The answer around the minimum staffing required, Paul, I think for clarity, what we have done in this case is both myself and Chris and Angela have worked very closely with the departments to be clear about what is, when we call a minimum staffing level, what is an acceptable staffing level for this. Benchmarking from a medical perspective, the Royal College of Emergency Medicine guidance is there, but is often professionally interpreted into something pragmatic, which is what is within this case. It is, the medical element is defined as medical, but actually is multi-professional. It's a rota for clinicians who are able to see and make decisions about patients who are not always doctors, of course. So it is broader than that. So this has been developed in very close collaboration with our emergency department staff. And equally, we've had external reviews, probably in most of the departments as well, linking across to this. It might be helpful, just Chris, I don't know whether you just want to say something about the nursing, because obviously there's a huge amount of work done here as well, if that's all right.
Yeah, sure. Yeah, of course.
I was going to pick up, I think, what Claire was saying about this being based on the Nurse Staffing Act and that clinical judgment. So that's absolutely what we've done from a nursing point of view, and following obviously external guidance on Royal College guidance and so forth. Very similar guidance around nursing numbers within emergency departments, and then use the same methodologies as we would do for the Nurse Staffing Act reviews, and the acuity. And I think just touching on something Claire was saying earlier, obviously we have probably more from an unregistered point of view. We have additional unregistered nurses within our departments now to support those patients, as Billy's pointed out, in designated areas, which as part of the programme is to improve the flow within our departments. So there may be some flexibility in that workforce going forward, but I think the registered workforce will be required on a long-term basis, because what we're seeing now from using temporary workforce, which is these lots of these staff that come routinely, regularly, they are actually regular staff. The temporary staff, they do many shifts for us. We're only seeing a fill rate of about 80% at the moment. So we still have, even though we're working to the rosters, then the fill rate of that roster is not to where we would need to be, and we would get to that fill rate obviously with substantive staff.
I agree completely with Gareth that there are other areas that we need to look at associated with where we have people who are not in substantive posts. Some of that is due to difficulties with recruitment, but some of it is due to where we will need to look at resetting of establishments, and some of that will be addressed with implementation of foundations of the future elements, but there are some other areas associated with emergency care as well, where we will need to look at that to be able to make sure that we have substantive staff in post where it is possible for us to be able to do so. Other aspects I might, if it's all right, Chair, hand across to some other people to pick up.
Thanks. Russell, I'll turn to you because there are quite a few aspects about finance and so on. So any thoughts from you, please?
Yeah, thank you, Job Chair. So just try to answer a few of those questions. I'll scribble them down and we'll do some work outside of that as well, of course. So just in terms of identification of the savings, I think there's a general need for us to underwrite our savings ask anyway within our programme. So this puts more challenge to an area that we're already struggling in terms of challenged on. And we will be discussing that later today, of course, but we do need to very quickly get to a point where we've underwritten our existing savings programme. Whilst government are asking all health boards to have done so by 30th of June, which is very close to today, we won't be in that position, so we will have to give a clear trajectory as to when we do so. This adds further challenge to that delivery, of course. So I think that's a really pertinent question from Claire, and we need to work outside this forum, able to bring back that assurance piece of work on general savings provision to the wider board. I would suggest we have a very limited time to do that piece of work. Paul's question around why was it not in the plan?
Yeah.
So when we constructed the plan, we did go out and request confirmation of what was required in the plan, and we did make provision in the plan for everything that was asked. Unfortunately, as the case has developed through early February, we found that there's been more layers added to that, and the case is built and built from that point. And of course, we've ended up today with a significantly higher ask than what we'd originally intended. That is why it wasn't there in the original plan. So we met the original ask that was put forward, and Parallel's team was working hard to pull all that information together through our colleagues out in the divisions. But obviously, we've ended up with a shortfall when we've got the final case before us. A little bit on Gareth's point. So, I'll give you a good example as to why, if we have a vacancy and we're driving that through expenditure. So gastroenterology is a great example where we can't recruit, and we're bringing in 2 or 3 additional consultants at almost double the price as what it would cost. So recruitment does play a big measure in terms of in terms of driving costs of temporary workforce. I'm sure there will be good examples where there are substantive staff on locum though, and we probably need to work to make sure that that's reflected in future budgets, of course. And as I think Clara mentions, once we go into foundations, we'll start to move some of that structure, and some of those posts will start to be resolved. Some of those issues will start to be resolved. And then I think the final point from me, I think it was Billy's point as well as Clara's point. I think they're 2 sides of the same issue. So the challenge here, we haven't seen great increases in footfall, but what we are seeing is real difficulty in flow out of the organisation. And that's our challenge point. And what we're doing here is making it safe whilst we get that flow correct. And what that does mean, though, is we are nursing patients in an ED provision where it was not designed to be done so. And that's why we can't normalise it through this case. And also we're building in costs because we're not moving those patients out through the wider environment. So I think, as Carol mentioned, that wider piece of work on flow is the more important one. And I think that is the key question as to why it's up to 3.9 million and how that finance and how that resource gets utilised as we go forward will depend upon those key developments we have in terms of flow out of the organisation.
Carol, I'll bring you in for final comments on this, please, before we go to approval or otherwise. Here we are.
Diolch Cadeirydd. Thanks. Listening to really great questions and strong responses as well. I think this case for me, and it's certainly taken a lot longer than I would have been satisfied with, to be frank. The colleagues know that the quality of the paper that's come through is significantly better than that we had a few months ago, and thanks to colleagues for the really hard work on this. It starts to demonstrate the start of a more mature journey on where we are with standards and how we assess ourselves against those standards. So Clara mentioned the Royal College of Emergency Medicine standards, etc. And there's GIRFT and all of those sorts of things. That is, in reality, part of the quality planning part of the QMS, the quality management system. And I would expect us to be quite systematic in all of our specialties as we move forward now into the foundations programme. And hence, Gareth, your point about, substantive staffing, or where there's a gap between, staffing levels and budgeted levels, all of that needs to come back through. Where are we service by service against the standards that are expected, and how do we best achieve those standards? And we do have some challenges because we're often providing 3 sets of services across our geography, where in a different place you would have one. And we've had some discussion with the with Healthcare Inspectorate Wales, for example, about paediatrics in emergency departments. If we were in Cardiff, we'd have one unit and we'd be able to have the benefit of the critical mass. So we are having to be very mindful of our more coastal, rural areas as well. So we're focusing on that. I think the biggest issue and challenge for us is dealing with the core issue, and that is supporting people through the system. We put a very ambitious target into the IMTP that we approved at the end of March as a board. And we've got external support, and we have had an informal presentation from Claire Old. The expectation is that now translates into 90-day operational plans. We have not had those full as yet, but I know through my weekly meetings, colleagues in Ysbyty Gwynedd and in Wrexham Myler Hospital have got probably the biggest challenges there. And I know that they are really trying to focus on that, but a lot more to do there. We can make shifts. Tir Gadref, I think, is that example that Gareth might have been referring to earlier about how we can be more creative to support community care for that 6-week period post-discharge. And then Billy, the corridor care and the pace of delivery. I don't know if this is good or not so good really, but one of the areas that's being held up as an exemplar is West Hertfordshire. They have more or less eradicated what you term as corridor care. I think we call it care in undesignated areas now. It took them 2 years, but we would want to learn from them and then fast track the work that happened. And whilst every health and care economy is different, what can we bring to North Wales in relation to what they've achieved? But there's no doubt about it that the sign off of this business case, I think, will improve safety. We will be all over this, Chair, if the board agree it, in terms of both implementation and impact. And our key aim is to reduce that overcrowding and to ensure that the patients who are in the department are well cared for. So I'll stop there, and diolch yn fawr for all of the work that's happened. Diolch, Cadeirydd.
Diolch yn fawr iawn, Carol. Diolch.
Thank you, Carol. Thank you for the contributions. I sense that there is wide-ranging support from members for this. I also sense that members would like to see this having an impact to create change. So thank you to everyone who's been involved in the work. Thanks to Clara and the rest of the team for bringing us to this point. We've got a number of things to approve. I'm going to try and summarize, if I can, that we note the reports from HAW, of course, and the reports that we have received from the government, that we also approve the investment of up to 3.9 million towards the emergency department in order to respond to the issues that have been coming up, that we acknowledge that this investment outside of our financial planning, and that we will therefore need to consider aspects to ensure that we receive the irrelevant funds and savings to make this possible, that we agree also on a period of time to introduce this over time, and that we are clear as to the outcome, performance and improvement that is required, that we depend on our operational team in order to investigate the improvements and the outcomes, and that we can evidence that, and that we agree on the appropriate committee, the committee that Gareth chairs, to have that overview that we need, and that we ensure consistent, regular reports to the board, and that members of the board receive the information in a timely manner, please. That we approve this investment, and so that we can move quickly, and that we do that in a wide-ranging, comprehensive way, not in an isolated way, so that we can make sure that this work happens over a wide area, as we have discussed this morning. That's the list for us to agree upon or not. Is there anyone who doesn't agree? No. Rhian. Can I don't disagree, but this asks us to note the findings of HIW. I haven't seen those findings. It's not available yet. So I've only seen what I've seen in the media. And so I'm slightly uncomfortable about that aspect. No, that's a good point. Clara, on the
some of us have seen, but it's not yet published, not in the public domain.
So I think the ask here is to note the overall totality of HIW reports over the last few years associated with our emergency departments, which is within the paper. The most recent one, which, as you say, is not yet published, the details that we have will be taken through in private next week through QSE to associate with the actions, and then we will decide how that then is reported into the next board meeting, given, as you say, that as yet we haven't had published reports, which are not due probably until the middle of August.
Yeah. Well, Pam can confirm situation.
Yeah, no, diolch yn fawr. And I think Rhian, you had mentioned in an email. So I think what might be helpful is, whilst it will be the private papers because of the current draft status, I think we could take as an action forum is to share more widely with board members, and if you're happy with that as an additional action. Yeah.
Diolch yn iawn. Good enough. Right.
Thank you very much for raising that. Right, is everyone happy to approve? Yes, excellent. Thank you all for your support, and again, onwards we go, starting from the minute we leave this meeting, really, without any delay. Right, that brings us to the end of our agenda today, which is a somewhat shorter agenda than usual. Can I thank everyone for their contribution? Thank you to the team for preparing the papers and supporting this meeting. May I thank Lowry for translating here in the room, and thank you, I think, to Iestyn for the translation online. The technology has worked almost flawlessly throughout the meeting, so we're grateful for that. That brings our meeting to a close. The end, so the next meeting, we've got 2 meetings in July. Those will be the annual general meeting, which is at Rhyl, and the full details will be available soon. And we've got usual meeting of the board again in July the 30th. That's a Thursday. That meeting will happen here. That brings the meeting to an end. Thank you for joining us. And I think what we need to do now is take a hydration break, as the footballers have.
Recording